you have any questions about the assignment, any problems that you have encountered so far, you can ask.
So can you explain a bit regarding assignment? What type of?
Yeah, what's the question? I'm also still working. Yeah, while I'm seeing the patients, I will speak to you. Just tell what's uh, the problem that you encountered. Did you all get the assignment format? Everybody?
Notes? No.
No. Maybe it was posted before you joined. Yeah, yeah. Okay. I'll post it today also. During the lecture after. Uh, yeah. We'll discuss after the lecture
Okay.
then, because then everybody has seen the assignment now?
Yes. Okay.
Assignment format now? It's basically what you have to do is to get a patient and analyze the patient on the topics that we are discussing in the class, like the wound biology, what sort of wound. In respect to wound biology, you have to write a chapter. So then dressing selection, how you did, how you came up with the dressing, your rationale, logic and all that you have to write. So it's basically regurgitating what we have told you and applying it into your patient. So such are the topics also. So I'll post it today, and then we'll discuss after the. We have some time after the listening. By then I would have finished also. So
Okay.
How to send the assignment via email?
yeah,
Oh.
it's via email. Yes.
Okay, then send the email address also.
Yeah.
When is the deadline to send the assignment?
Yeah, that Dr. Shashi will tell. That will be posted in the group. So that is, I mean, that's the council decides on that now. Usually, it's 1 week after the course, the end of the course.
Okay. Without the hands-on training also, we will get the certificate, no? If we are unable to participate in the hands-on training, also we will get the certificate.
Yeah, once you have submitted the assignment and we have accepted it, then you will get the successful completion certificate. Apparently, because of this ministry regulations, there will be no certificates of participation this time, because it comes to the ETR. So we'll be issuing. I think we'll be issuing another certificate for the hands-on. I'm not sure. Dr. Shashi should answer that actually.
Okay, thank you.
So is there any word limit for the assignment?
Yes, there is. Everything was in the format. Chitira there, Chitira, can you please repost the assignment this thing? If you have it. I think I have posted in the group some before the start of the course.
Hi, Sashi, Tushar. hello, Tushan. I'll ask Chitira to make you co-host.
Yeah, yes, please. Yeah.
Yeah. Chitira, if you're there. Yeah. Yeah, I think it's okay now. So let me introduce our speaker. Uh, so we have Dr. Tushan Gunaratne, who is a consultant vascular and transplant surgeon, as well as a senior lecturer in surgery in the Faculty of Medicine, University of Colombo. So over to you, Tushan. You're muted. We can't hear.
Sorry, apologies.
Okay.
You okay?
And it's not in presentation mode. If you can put it in.
So thank you, Sashi. Thank you, Tushita, Dr. Ranga, if he's around, the college for this very useful project. The second or third day we're doing this now. So over the next 40 to 45 minutes, let me just talk a little bit about wound bed preparation towards getting a proper wound healing sorted out. I think some content has already been shared. You know a little bit about the stuff, but I'll give a little bit of background, and then we'll see how the wound bed preparation works. If anybody wants to stop in between, that is fine. Please do feel free to either raise your hand or unmute yourself and ask any question. That is fine. Or else I'll just continue talking a little bit about the whole topic given to me. So essentially, to understand wound bed preparation, a little bit of biology also is required. Tushita, am I doing bilingual or? Oh, sorry, Sashi.
No.
English.
All doctors. Yeah, these are all doctors.
Fine. Okay, thanks. So a little bit of biology, because it's important to understand a little bit of it so that it makes sense and talk about how the wound healing and happens and how the wound bed is important. End of the day, anyway, any breach in the epithelium is considered wound. If they've got a skin surface, if that surface is disturbed or breached, then that is a wound. When this is a wound that is acute, that is often what we often see. All of us will have this at some point. We get a little wound, a heart wound. That's different. But for whatever reason, sometimes the wound doesn't heal. And that wound continues to stay on and becomes a chronic wound. So most of the difficulty in managing a wound is basically with this chronic wound. Acute wounds have its own different problems in management. But for this particular discussion, we're talking only about chronic wounds. Now, wound healing and how this wound heals is a very complex process. A lot of things are involved, but generally we talk about two ways the wound heals. Either the wound is closed at the same time, and the wound is nicely healed with a scar along the incision that is made. All of our surgeries are like that. Sometimes you can't close it at the same time. You'll allow the wound to heal on its own. Then you get that scar and that whole secondary intention wound healing. Now, whatever happens when the breaching of the epithelium happens, the problem is bugs and things always try and come inside. So the first thing about it is it has a little platelet blood clot that forms to try and make sure no further bugs from outside can come inside. Once that happens, you find a lot of stuff is included. That's your extracellular matrix is entering into the space of the dead space. Give me a little second to So this is important because that fills this dead space and makes sure nothing else happens afterwards. Into this space, all the very important things are included: enzymes, cells, growth factors, etc., etc. Now, at some point, that epithelium basal membrane is going to close in and cover that gap that is there in the skin. And when that is happened, then the epidermis grows from there and you find the skin is nicely covered. So if you look at the whole process of how this happens, there are 4 important steps. One is this hemostasis, a plug of blood clots that helps to seal off. And then there's an inflammatory phase where all these important cells, tissue enzymes, cellular factors, cytokines, they come into this space and try and help to fight the bugs and help to grow various growth factors and tissue factors. Once those cells are there, it lays down what we call the extracellular matrix of the granulation tissue. And this requires oxygen, new vessels. And once that layer is there, the top skin layer closes off. For whatever reason, at the end of it, so later on, the remodeling happens and we find a big scar initially, gradually becomes a smaller scar. So this is not like in one phase it happens and then the first phase, and the next phase, and the next phase afterwards. These phases overlap with each other. It's a continuous process. Some parts of the wound might be in one phase, while the other parts of the wound are already gone into epithelial phases. So whatever reason, if it doesn't work and it gets stuck in one place, then that is what's called a chronic wound. This natural process where you see certain areas are in proliferation, certain areas are epithelializing, certain parts are still perhaps proliferating, but now it's all scar formation. At some point, some of these all remodel, and you can see how big that initial wound was. Once a mature scar is established, it's a remodeled, nice, fine scar, and that is one that is healed by secondary intention. So what we want at the end of the day is to get that wound to become a healed scar. What we need to do is to put all the very important friendly factors, remove whatever negative, bad factors out of it. If that is done, then the wound will gradually heal. So the important thing is when you're doing all of these things is remember that you look at the entire patient and not just a wound per se. Wound care does not mean dressing the wound. Wound care is not about just putting another dressing and taking one out and putting a new one in. Dressings are not the ones that heal the ulcers. Essentially, it is the body that heals the ulcer. What we do is to prepare the environment for the body, give the right environment so the body can heal the wound on its own. So the concept of wound bed preparation revolves around this concept to ensure we give the wound bed the right environment. That is what is required. We'll talk about it a little while later on, to give the right wound bed environment so the body can heal on its own. And we need to identify why a particular wound did not progress beyond that particular phase, why it got stuck in a particular phase. Therefore, we can then try and correct those requirements, correct those problems, and get the wound healing into the next phase and beyond. So, first of all, you see a patient with a chronic ulcer, a chronic wound. The most important thing is to try and identify and treat the primary cause. Without sorting that primary cause, whatever dressings you put, whatever amount of money you spend on trying doing various things, the wound will not heal. Essentially, there are many primary causes, but generally in our setup, there are 3 important things. So first part of your assessment, first part of managing the wound is to make sure that at least these 3 important primary causes have been looked at. And they are the VIPs of this whole problem, the very important factors, the very important people. V is for vascular, I is for infection and immunopathy, and P is for pressure or trauma, basically. So you need to think of all these things. You look at the wound to make sure that these initial ones have been looked at, corrected, sorted out. So if you look at the vascular, there are 3 important vessels that we talk about: the arteries, the veins, and the lymphatics. I'll make a quick note of this. I won't spend too much of time. But if you think the arterial system is not intact, very important things are to look for the skin. if you have a Doppler measurement available, do check the Doppler pressures at these patients. Look at the wound. Sometimes looking at the wound alone might show you an important physical signs, important clue a problem is going on. When you see the picture on the left with absolute dry gangrene, those are dry, black, parched, hard, dead toes, that is very clear. There is infection, there is ischemia issue going on. But the wound on the right side is not so very clear. It got some redness happening, it got some granulation happening. It is not profoundly ischemic. You see a little black rim. Sometimes this wound might even bleed when you debride it. So those are little gray areas that are very difficult to figure out. But it is important that you suspect ischemia when you think of a problem like this. So remember that all of these signs and symptoms might not be there. BPI is not easily available. Very important diagnostic tools are not easily available in most of our setup. So it's a clinical judgment that is required to see exactly what is going on. Now, apart from the arteries, the next important thing, I'll look for the veins. Because venous problems are probably much more common. And anything that damages the way the valves function and the veins function, so the veins, the venous blood is not pushed up and is not kept up. If it doesn't work like that, it keeps on pooling down in the feet, causes a lot of pressure building up. And that is why you find some venous ulcers happening. So if you look at the system, there can be two different types of systems. You have a deep venous system. So for example, somebody with a history of DVT, for example, somebody with a history of trauma might have a deep venous issue. And then you have the superficial venous system, the varicose veins we all know about. So it is very important that you look at the person, you look at the wound, is it venous? Because if it's venous, the management is different. There's no point in putting fancy dressings. You got to sort that venous hypertension out. Lymphedema management is much the same, perhaps a little bit more complicated, but the same principle in terms of the management requires you to add compression. No matter what dressings you use, no matter how much you prepare the wound bed, unless you saw that initial primary problem out, these wounds will not heal. The last one was P, pressure. So pressure is about abnormal pressure distribution. We all of us, we have a decent shaped foot. When we walk, there's an equal pressure distribution along the plantar surface. If there is a deformity in one of these patients, sorry, it's thick on the sides, my apologies for that. If there's a deformity, what's going to happen is that causes extra pressure distribution and abnormal pressure distribution. So certain areas of the foot will be at higher risk of getting increased pressure, and those areas will be at higher risk of having an ulcer. So if a patient has an ulcer and there's a deformity and the pressure is important, it is important to realize that, because unless you solve that out, you can't sort this initial problem out. The wound will never heal. You can put as much as fancy dressing as you want. If you don't take the pressure off, that pressure point, that wound is never going to heal. So initial step, before you even think about dressings, think about wound preparation, think, has the primary cause been addressed? For that, unless you look for it, you'll never see it. There are three important ones at least: your V for vascular, I for infection, and P for pressure. If it is ischemia, revascularize. If it's venous, sort the venous problem out and add compression. If it's lymphatic, it is often only compression. Lymphatic surgery doesn't often work in our setup. If the issue is pressure and neuropathy and unequal pressure distribution, you got to do something to sort offloading out and something to try and see if you can correct the deformity. Right. So if you look at the wound bed preparation paradigm, this is what the guidelines say. If you find a person with a chronic wound, first step, identify, treat the primary cause. Once you do decide that the primary cause has been addressed, then it is up to you to decide, is this wound one that has the ability to heal? Is it worthwhile healing? Is it healable? You often find, especially in palliative care, patients who are having cancer, who are bedbound, they're on a bed, they got a heel ulcer due to pressure distributions, and they have got bilateral pressure ulcers, they have poor nutrition, they're not going to be having a long prognostic life. Their life expectancy might be 3 months. They might be on chemotherapy, on ANG. Probably it's not worthwhile trying to spend all that money and effort to try and heal the wound. Perhaps it is much kinder to put the patient on a palliative wound care pathway. So it is up to you to decide before you embark on the wound bed preparation, to decide where you are in terms of your objectives and goals of managing this patient. If it is healable, you move forwards. If it's not healable, despite being able to identify and treat the cause, you might want to remove that leg perhaps. For some people, the kindest thing is to console and keep them on a palliative care pathway, especially when it comes to cancer and advanced disease. Right. Assuming that you've done all of these things, assuming that the patient is for a healing wound, then you come to your local wound care. And that is about the wound bed preparation. Now, it's famous saying, time does not heal all wounds. But when it comes to wound care and wound bed preparation, this time concept is well established. It is got a little advanced, and some more new things have been included, but I'll just stick to time for the moment. So what time talks about, it's an acronym. It stands for 4 things: TIME. T is for tissue management, I for infection and inflammation control, M for moisture, and E is about the age of the wound. The first 3 are the most crucial parts of this whole wound bed preparation. Right. So what do you do when you see a patient? Sorry, when you see the wound, the first thing you do is to see, is the wound requiring a debridement? A debridement is required to have a good tissue sorted out. We look at that first. Essentially, if you forget about the whole different types and you don't want to become too scientific, you're a practical person, I often say there are 4 different types and colors of tissue. You have black color, you have yellow color, you have red and pink. Red is perfectly fine. That is what we want. Pink means the red has gradually becoming epithelializing, and that is what we want at the end of it. Anything that is not red or pink should not necessarily be in the wound, and that should be removed from the wound to make sure the wound heals. You find a wound will have different types of and colors of multiple wound of different tissue types. Here you might have red tissues, you might have pink tissues, you have white tissues, black tissues. Essentially, what you want is a nice granitic wound. If that happens, the wound can gradually epithelialize. Now, debridement is about trying to make sure you remove those non-viable or necrotic or infective tissue, because if you leave them, they can impede the wound healing process. Now, how do you then remove those unhealthy? You to decide. There are different options. Surgery is only one of these options. It's often what we use in a surgical practice as a surgeon, but it is actually the most harmful of all your options. When you do a surgery or a cleanup, it is very rapid. That is that much I'll agree, especially if you want to control infection or bad tissue, remove it faster. That is the easiest and the most fastest way. But you will inadvertently remove healthy tissue as well, and you will damage a lot of architecture. So there are other methods as well: autolytic debridement, enzymatic debridement, biological debridement, mechanical debridement. Mechanical not so much in our setup, but what you want to do is to remove those unhealthy tissue and get them gradually to become more and more red and at some point pink. So you decide what is the best method for you. This is a surgical debridement, gone to theater and cleaned up. It is perhaps the gold standard and the fastest, but we got to be very careful. Everybody can't do it. Transfer to a surgical ward, and that requires time, anesthesia, pain, all those things are there. Mechanical requires a specific types of devices which you don't have in our setup. Wasajet or hydropressure or ultrasound, fracturing of the biofilm. These things are described, not easily available, and perhaps not cost effective as well for most of us. The important thing to realize is that, especially if you're not a surgeon, that you don't need sharp debridement for all wounds. You can use wound dressings. You can use the wound bed. You can use the moisture balance of the wound to try and do a debridement as well. Most of this yellow stuff that you can see sometimes can get desloughed. It can become more dilute, can become more watery. And if you use a gauze swab or something on top, it can get stuck or absorbed onto the swab. And when you remove those dressings, the wound can gradually become more and more clean. So that's essentially autolytic debridement. You can use saline, you can use acetic acid. So various types of dressings you can also use to try and debride the wound and remove those unhealthy tissues and get them to become more and more red and pink. That is about the T component of the time concept. Now, what is I? I is about infection and inflammation. What is important here is to realize is that every single wound you are going to see as a chronic wound will have some degree of bugs. And that is because the entire environment that we are living in has microorganisms. So every single wound will have a contamination. Now, just because there's a bug, it's not a problem. Often lower levels of bacteria probably useful, if at all, rather than becoming harmful. But when it becomes higher concentrations and they cause more inflammatory response and they end up causing host tissue damage, then it's a problem. Then that can cause it to invade into local tissues, enter into the bloodstream, cause other organs to get damaged, etc., etc. So the idea of the I component is to try and reduce the bioburden, the microbiological burden that is there. We can sometimes do this with systemic antibiotics, either tablets or IVs, etc. We can use topical antibiotics, not often done nowadays. There's a time when just very commonly used in chronic wounds. It still happens in neurosurgery or orthopedic surgery where you put various topical antibiotics near the bones. But whatever degree of antibiotics you use, if it is in contamination with the host tissue or contact, it is going to cause resistance. And that is a huge problem when it comes to wound care and wound infections and antibiotics in our setup. So instead of antibiotics, which are basically a medical way of fighting the bug and killing the bug, there are antimicrobial agents. They are perhaps the best thing to use because some of them have hardly ever demonstrated any resistance. They can fight a wider spectrum of bugs. They don't cause reactions. They don't cause sensitivities. And a dressing is often useful because it can help to do various things at the same time. I'll talk a little bit later on as well. So why you need to figure out this is because you need to decide a requirement for a dressing or a wound bed preparation that involves infection control. How do we know that there is actually infection happening? No point just doing a wound swab. That is quite useless because we all know contamination can be there. So what are the clinical signs and clinical features when you see a wound that might help you to decide there is wound infection going on, either local or deep? So there are various ways of looking into this. I'm not going to talk too much and make it more scientific and theoretical. If anybody wants to read up and go through these two criteria, they're most welcome to do so. There's something called a NERDS criteria and something called a Stone's criteria. This is very straightforward. It's not very complicated. But basically, what you're trying to see is, are there little subtle signs to look for wound infections in a patient? Now, just to give a little small brief about it, if you find the wound is not healing, it's gradually getting worse. The exudate is too much. There is a little bit of odor happening. There's a lot of debris. It is sometimes too unhealthy, too offensive, too much of exudate. Even when there isn't frank evidence of pus or the redness or the inflammation or the erythema or the vomit, if those finer tunes are there, then that is sort of what we call the NERDS criteria. N for non-healing, E for exudate, R is about red and very hyper bleeding. D is about having and S is for the smell or the odor. So those are some criteria that are available for you to say there's a local wound infection happening. Obviously, the patient is having fever, is unwell, tachycardic, then there's nothing to discuss. The guy is obviously in sepsis. If there is pus coming out when you squeeze the wound, then there's nothing to discuss. There's obviously wound infection happening. But sometimes, especially in diabetes, these little subtle signs that we think are very obvious aren't there. By the time they become obvious, the wounds got infected and festered for many days before. Now, that was about nuts. Stones is not too different, it's little much of the same thing, but this is looking at the deeper and surrounding infection. Obviously, if there's deeper tissue involvement, the surrounding tissue involvement, we'll find things like warmth, we'll find it will increase temperature, you find a little erythema. The wound is naturally going to get bigger and bigger. You find sometimes bones and joints and things are exposed. The wound has the offensive odor. So all those little things are there to say there is little more than just the local wound infection. There might be deep infection. If it is only local infection and there is no systemic infection, there is no need to give topical treatment, systemic therapy, either oral antibiotics or even IV is not required. If you think there is local invasion and more deep tissue involvement, then giving a topical treatment only is going to be harmful. You need to think of systemic therapy as well. So those things are there to help you to figure out, one, is there infection? Two, is it localized or deep or more surrounding systemic? And then you can plan, do I want to use a local antimicrobial dressing? Do I want to use an antibiotic? Does it have to be a tablet? Can it be an IV? Etc., etc. So once you have done the T, that is, you have looked at the wound tissue and decided if the wound needs a debridement. If you are done and looked for infection and sourced that infection out. Again, one thing I need to tell is that if you think of T and I, they often sometimes go together, especially when there's a lot of pus pockets, abscesses, dead tissue that are infected. You got to combine the infection control with debridement as well. And that is the beauty of surgical debridement, which can rapidly open up dead spaces, open up pus pockets, remove the pus, etc., etc. So once that is done, then you probably look for infection, you're given the right dressings, and you then have to move on to the M component of time concept. Now, essentially, you got to have the right wound bed with the optimum moisture if you want to heal a wound. Wound moisture is much like the human being. It's not too different. You got to make sure that the patient has the right degree of humidity if you want the patient to be comfortable. Obviously, the patient is too dry, that's also not going to help. If you want the patient to be too wet, again, that's not going to help. So get the right moisture balance is important for any patient. Similarly, for the wound, the same thing is required. What we now talk about in modern wound care is what's called moist wound healing. So for whatever reasons, and for many reasons, if you have the right moisture balance, the wound will heal faster. Whether the enzymes work better, whether the tissue migration happens faster, cell migration happens faster, don't have unhealthy scab over the wound bed, it preserves the growth factors, cytokines work better, pain is less, dressing size is put. All these things are helpful if you have the right moisture balance. So the wounds can have a range from being too dry to too wet. And you need to decide how to use the appropriate dressing and to get the right wound bed prepared for this purpose. I'm sure there's a topic later on wound dressings, and this will be discussed by why you use a particular type of dressings that donate moisture is because the wound is too dry. As you go on this ladder of degree of moisture, you find you gradually getting into dressings that absorb moisture, like foam dressings and alginate, for example. Later on at the top end, they can absorb a lot of moisture. So the wound will change from time to time. The wound will sometimes become too dry, it will become little too wet, become little too dry. As the wound changes its moisture, you too have to decide on what dressings therefore you want to use. So the beauty of knowing this is the science to understand that you can think of the exact type of dressings you want. Now, there are also certain dressings that combine these things. Again, I'm sure they will talk to you later on, and there will be wound dressings that help to debride, to add moisture, to control infection, etc., etc. Yeah. So E is the last part, and I don't want to talk too much about it. But basically, despite having a debrided wound, despite sorting infection out, despite having the right moisture balance, still some wounds don't close off. They don't heal, they don't finish healing. They're stalled because the epithelium isn't growing. And that is why you find things like vac therapies, growth factors, collagens. These sort of things are there to try and help those things. Very costly. Often, if you are able to sort out those initial things, you gradually get the wound to heal. So, just to summarize the whole thing over again, this is what the wound bed preparation, the wound care that is required for this purpose. Remember, the initial thing you want to do, first of all, is to get the right important thing is to find that the initial primary cause has been addressed. Determine if the ability to heal the wound is there or not. What is the ability? What is our end goal? If you think you need to heal and you can heal and the patient is okay to go on this journey with you, because it's a long journey to heal these wounds, then you start on the local wound care, which could be debridement for the T component, inflammation, infection control for the I component, moisture balance for the M component, and the H effect for the E component. Remember, whatever you do, you need to be in communication, discussion with the patient and the family as well. It's a partnership that you take on to try and heal this wound. So, trying to put all these things together, if you can think of only this slide at the end of this whole talk, that's actually more than enough for me. If you want to heal a wound that is chronic, the important thing is to realize that there's something wrong in this whole setup. The system has been blunted or stalled in one particular phase. So it's important before you do anything to figure out, has the primary cause been addressed? And for that, you got to be actively looking for the primary causes. At least think of the V, the vascular supply, arteries, vein, lymphatics. At least think of infection, which can be superficial, which can be deep, which can be tissue, which can be bone, which can be joint, and think of pressure imbalance, neuropathy, repeated trauma, etc., etc. Subsequently, having sorted those out, having addressed those, you move on to the wound bed preparation, assuming that you had a chat with the family and the patient and you agreed to go on a wound healing pathway. And the time concept is very important for this purpose. Putting all these things together is holistic wound care. And that is why the patient, the society, all of those are important to try and heal this wound. So people often try and fight around who should do wounds. The fact that you have been interested enough to join such a course and to learn and to update yourself, it means you have an interest in healing wound. That is very, very important. And it's that interest that is important to heal these wounds than anything else, because you will pay attention to the wound than anybody else, right? So what is important is you continue your passion, be more committed, keep on educating yourself, be involved. Often, if you think you need some help, do communicate with people around you, and they'll help to solve these problems out. If you need to revascularize, you got to send for vascular opinion. If you need to sort the venous out, you got to send for vascular opinion. If you want to sort infection in surgery, you got to have a chat with the nearby surgeons. If you want to start antibiotics, you got to get in touch with sometimes with microbiologists and look at the guidelines. If you want to get the pressure sorted out, you need some help with orthotics and prosthesis and insoles or modified shootwear. So all that communication is required because it's not one person trying to heal this sorting these wounds out. So thank you for that. Think about temps at the end. Anybody wants to ask questions, I'm more than happy to help out. I hope I was able to give a little idea as to how and why we think of from a wound bed point of view, the steps required to try and heal these wounds. So thank you for that. I'll stop at that point. The other speakers will come in afterward. But if anybody wants to ask some stuff, feel free to ask questions. No issues at all. It's perfectly okay. Just wondering if I've gone beyond the topic. See if get these questions. Any special consideration in treating a pyoderma gangrenous wound? So pyoderma gangrenous is part of those. If you look at that initial VIP, I talked about those initial primary causes. I talked only about the most common stuff. You have a subset of problems that are primary, not very common in our setup. These can be things like vascularities, things like foreign bodies, things like dermatological problems, things like autoimmune problems, things like chronic inflammatory like tuberculosis. You find purulence and gangrene, both common for a lot of diabetic as well as for this specific particular pyoderma. And do read about it. The problem with pyoderma gangrenosum is that essentially it does not require you to control. If there's diabetic foot sepsis, there's infection, there's gangrene. Often the first line is to debride, because that will help to sort the necrotic burden, help to sort the bioburden. For pyoderma gangrene, we've got to be a little careful. The management is not to rush into debridement. The management often sometimes includes steroids. So therefore, it's important to be in touch with the dermatological colleagues for somebody, and you find it's a systemic problem. It's not a focal problem, and therefore the patient's wounds are different. You find a systemic distribution, bilateral legs, not in a typical spot. It can be around the ankles, shins, legs throughout. Sometimes upper limbs are also involved. They're very, very painful. Diabetic neuropathic feet are different to this. And those sort of wounds, if you keep on debriding and cutting, it can actually get worse, because the problem is not infection driving it. It's an inflammatory process that has some autoimmune component to it. These patients often need some immune modulating agents. So sometimes high dose steroids are required. I hope that was helpful for you, Vimarshini. Yeah. If there's a wound in ankle surrounding area, pitting edema and can't type it. So as I told about this pulse examination or the ischemia, we like to be able to see all these signs and symptoms. We like to have a patient who will be a claudicant, for example. We would like to be a patient who's got rest pain. That is, the patient has so bad pain, can't sleep at the night, needs morphine, hanging the foot off the bed. We like to see an absence. We like to see a dead, dry, gangrene black tissue. This is not often the case. Often it's very difficult to feel pulses. You never find claudication in diabetics often. You never find rest pain. You have a chronic wound that's been going on and on. The legs are swollen because of heart failure and tissue edema and inflammation. It's impossible to feel a pulse. And therefore, you sometimes cannot rely, therefore, on those hard signs. If you have an ankle brachial pressure index, that is fine. But if you do use Doppler, you might realize that the ankle brachial pressure index also won't work for diabetic people. And then therefore you need a toe pressure device. And that is not hardly available in most centers. So if you do find that these symptoms and signs can't be elicited, then you got to think of your clinical judgment. a very profoundly ischemic wound is not an issue, but you find this borderline infection, borderline ischemia, often in diabetes. And if you think the wound's not healing, the color is not great, the smell is not great, it is gradually getting worse. And I can't feel a pulse as well, or the wound keeps on getting worse despite all things I'm doing. Sometimes you got mixed ulcers, venous and ischemia. Then it is better to sometimes refer people to vascular surgeon because they are probably the best people to be able to understand and assess the blood supply. And if there was no claims from the vascular surgeon first, why did you refer this? They say it's all good, keep on carrying on your work. You are welcome to post compression, wounded, don't worry. So sometimes it's a clinical judgment, and you might need more sophisticated investigations like duplex scans or imaging for those people. Alexand, venous ulcers. Is it must to correct the varicose veins by surgical intervention for better healing, or shall we wait to heal with stockings? Some people refuse for surgery. So, very important thing. So basically, if you have a patient with a venous hypertension and a venous ulcer, there are two important components that are essential to heal this wound. You need compression. You can't not have compression and heal venous ulcers. Second thing is to correct the venous anatomy or the venous problem. Now, you are probably going to be able to heal a wound with compression alone. Current guidelines and the newest studies, if you want to quote these studies, the EVRA trial is the newest trial available. It's called EBR or EVRA trial. What is clear is that if you sort the varicose veins out sooner, the wound will heal faster. What is well known, regardless, is that if you don't sort those varicose veins out, the chance of the veins ulcer coming back is much, much faster. So recurrence rates are a lot higher if you don't sort the varicose veins out. Your compression stockings or your compression bandaging, stockings are difficult to use when you have an active wound. You therefore need the patient to be on bandaging. It is very difficult for a patient to have a bandage on for a long time. But it is very important to assess and treat the varicose veins as soon as possible for a patient with your venous ulcer while your compression is continuing, whether it is a stocking or more preferably a multi-layer compression bandaging for a patient with an active venous ulcer. So I hope that was clear. Sorry. Yeah. Ahmed went to order duplex. I wouldn't do that. I wouldn't rely on a duplex scan, arterial duplex scan by radiologist for a simple reason. If you do think the wound is ischemic and you wait for duplex scan, and that's going to take some time because most centers radiology will give a date that will take about 3-4 weeks. Difficult to interpret the duplex scan because they'll give a finding at the end which is very gray. They'll say there is diffuse disease compatible with PVD. Often these people will have PVD. So if you do feel like the wound has a blood supply problem, my honest opinion, not because I'm a vascular surgeon, but my honest opinion is to refer a patient, such as that patient, to the nearest vascular regional center. If you don't have one that is close by, then do refer to the general surgeons because they'll also be able to figure things out. The difficulty and the pitfall of doing a duplex scan is that you will waste time. During that time, the wound will keep on getting infected. People will continue to debride, and therefore the wound will become worse and worse with time. And therefore, if it is ischemic, you probably make it much worse and you lose the chance of saving the leg if you wait and rely for a duplex scan. Whereas if you refer such a patient to a vascular unit, they'll probably do a duplex scan the next day by themselves and they can plan and make assessment. Because we are in a national tertiary center, when we don't have the right tools to decide on whether the wound is ischemic, we might do a duplex scan, but the role of the duplex scan for us is not to diagnose ischemia, but is to plan. Can the patient have an angioplasty? Can the patient have a bypass? Example. So I'm not saying not to do duplex scans, but be very careful, and it will depend on your unit, your availability of a duplex scan done fast, your radiologist who does the duplex scan, and your ability to interpret that report as well. So few things, there are a lot of subjectivity, so be careful with the duplex scan. Yeah, so thank you so much for all those questions you asked. Always useful to discuss something, and gives a little bit more context. Probably I finished my time slot as well, so I probably best to hand over control to the hosts. Tusita Sashi want to take over. I hope that is useful. Feel free to contact us. We'll be having chat again later on. I myself or Tusita will probably share some information if anybody wants to go into a little bit more depth in wound care and wound healing. The Columbia University has a certificate course. It's a bit of a complex and a bit more serious. It's a 3-month long course, a little bit more expensive, so it's not for everyone. But anybody who wants to pursue wound care and limb salvage, I will share some details, and Tusi will also share. I'm sure he's got the same. He's part of our team there as well. He'll be able to share some information for a more formal education on wound care as well. Right. So thank you again.
Thank you, Dr. Tushan, and thank you for joining. And I think that information is very valuable. So I will ask to share that information about the certificate course as well with the participants. And we will be sharing the recording of this session with the participants who missed it, because we have 130 in the batch this year. So yeah, so the recording will be shared. And thank you so much for joining. And say something.
Yeah, fantastic lecture as always. So, Tushan, and thank you very much for agreeing to do all this. Let's discuss a little bit about the assignment. I think now everybody must have seen what the assignment is, and it's very easy. Just fill in the gap. I have laid down all the necessary topics. Any problems you encountered about the assignment format and all? And some people have already started working, and I got some questions also in WhatsApp regarding this format and all that. So others also just hurry up and start. Otherwise, I mean, you have to write during your busy schedules, no? And it's sometimes it's a little difficult to start. Because you are not geared to do this, probably, writing assignment, analyzing and all that. So it's start now, and let's we are there to help you. Anybody has any questions on that?
Looks like we don't have any questions at the moment, so I think we can round up. If you have any questions, I think you can post in the WhatsApp. And next Tuesday, we'll have the final online session. After that, we'll be having the in-person session. So we will be informing you how to register for the hands-on training session during the next session on Tuesday. And thank you very much for joining. Thank you, Tusita. And thank you once again, Dr. Tushan and Chitra for being a great host. And thank you and have a good night.
Thank you, Sashi. Thank you very much all.
Thank you all.
Thank you.